Hello, my name is Ijanae Holman-Allgood, and today I'll be talking about ovarian cancer. We'll be going over the history and background, signs and symptoms, diagnosis, some of the high-risk populations, prevention strategies, and case management, and what's going on currently, and why this is a big public health issue. Ovarian cancer, according to the NIH, is cancer that forms in the tissues of the ovary, where the ova or the eggs are formed. Most ovarian cancers are either epithelial cancers, which means cancer cells that are the cells on the surface of the ovary, and the malignant ones are the germ cell tumors, which are the cancers that begins in the eggs. 90% of all ovarian cancers are the epithelial type. Ovarian cancer is the sixth most common tumor in women. It's the #1 cause of gynecological cancer deaths in the United States. More than 200,000 women in the U.S. have ovarian cancer. 6.6 new cases are diagnosed each year out of 100,000 women. And that makes up 4% of all cancers diagnosed in a woman each year. 1 in 78 women are diagnosed with ovarian cancer in their lifetime. Ovarian cancer, even though it's the sixth most common tumor, it's the #1 leader in gynecological cancer deaths, it's very rare. So why is it causing all these deaths? We've known about ovarian cancer history for over 150 years. The mortality rate has not decreased, but the incident rate has gone up. Why? Because ovarian cancer is not diagnosed until late. It goes undetected for so long, and then when it's finally found, you're in advanced stages. So what is advanced stages? Stage 1? Well, before you get to stage 1, this is a healthy woman. She has no ovarian cancer. Stage 1, it's confined to the ovaries. Stage 2, it's confined to the reproductive organs, the ovaries, fallopian tubes, the uterus, just in the pelvic region. Stage 3, which is when most women find out they have ovarian cancer, the cancer spreads to other parts of the body within the abdomen. And then stage 4, cancer spreads beyond the abdomen, so you can have mets to the brain, for example. What are some signs and symptoms that women come to their physicians and talk about? So they say, I'm fairly tired, or I feel constipated. I'm having trouble eating, and when I do eat, I get full very quickly. So they complain about abnormal vaginal bleeding, abnormal vaginal discharge. They complain about changes in their bowel habits, urinary symptoms such as urinary frequency and urgency, and then a common one like pain and pressure in your pelvis and abdomen. But these signs and symptoms are very vague, and they can be a cause of a different, like benign disease or a different type of cancer. So they're not very like telltale. So to diagnose ovarian cancer, the United States Prevention Task Force and the American Academy of Family Physicians recommend there's no routine screening for ovarian cancer in asymptomatic women. It's not like it's like a pap test or a pap smear is for cervical cancer. That's routine screening. There's routine regulations for women to get a pap smear every 3 to 5 years. We don't have that in place, and the recommendations do not recommend that we screen asymptomatic women. They do recommend that women with family history associated with increased risk or harmful BRCA mutations be referred for genetic counseling, because then your risk of possibly getting ovarian cancer increases. When you're evaluating someone for ovarian cancer, a doctor has to have high clinical suspicion to say, okay, let's take this another step forward, or pertinent risk factors or family history. So if a woman comes in and she complains of signs and symptoms that we've listed previously, her doctor is very suspicious, her gynecologist is going to perform a rectovaginal exam and looking for irregularities, as well as a full physical exam to look at for other signs and symptoms, like perineoplastic symptoms, or any lymph nodes enlarged. Is she having any memory issues? Because like I said before, ovarian cancer is caught in stage 3 and 4. So sometimes it could have already been metastasized to certain areas of the body, and signs will start to show from that. What imaging can be done to diagnose? So if a doctor does have high clinical suspicion, they possibly feel an irregularity, or the woman's still complaining, you can do a transvaginal ultrasound. You can do an abdominal and pelvic CT with contrast. To note, if they're allergic to contrast, you can order an a pelvic MRI. So the transvaginal ultrasound and the abdominal CT, and they will not tell you if it's cancerous or not, but they will tell you if there's a mass there. Is there an adnexal mass there? Does it look heterogeneous, or what does it look like? How does it differentiate? Please, it will be described, and that will lead you, is this cancer, this not cancer, maybe, maybe not. Some blood tests you can do, the CBC, a liver function test, and calcium can be done, because like I said before, if it has metastasized, it could metastasize to different parts of the body. Or we can look for paraneoplastic syndrome. So if calcium is high. One blood test that is routinely run is when she's asymptomatic, or when you think she's not asymptomatic, but when she's symptomatic, or if she has a history of family history of different genetic mutations, the CA125 antigen. It's not very specific, but it is sensitive, because it could be falsely elevated during menstruation, fibroids, and uterine cancer. So it's not very specific for ovarian cancer, but it is a good test. And the definitive test would be a biopsy. So this is just a flow chart to show you if she does come in with symptoms, yes, and her physical and history, including her genetic risk, say we suspect ovarian cancer, yes. We do an ultrasound, we do her CA125, we still suspect it, we're going to refer her out. But if she doesn't have an adnexal mass, there's no suspicion, we're going to have to work her up in a different way. If she doesn't have any symptoms, we're going to do a risk assessment. What's her family history like? Does she have any BRCA1, BRCA2? We'll talk about high-risk populations, what type of family history we'll be looking for. And if she has that, let's refer her to genetic counseling and testing and see, is she high-risk herself? And if she is, and she does have those high-risk mutations, we're going to refer her out to gyn-onc, which is gynecological oncology. If not, consider long-term hormonal contraceptive use. And we'll talk about why, we'll talk about this, but birth control is a good preventative measure. Some high-risk populations that are at risk for ovarian cancer. Again, family history of ovarian, breast, colon cancer, genetic mutations, like we talked about before, BRCA1, BRCA2 mutations. The risk for ovarian cancer it goes from 27 to 44% if you have a BRCA1, BRCA2 mutation, compared to the general population, which is only 1%. So that's a very big difference. The Lynch syndrome, risk of Lynch syndrome is 9 to 12% of getting ovarian cancer. Lee-Vermeer syndrome. Also, so women who are menopausal or older age, 90% of the women diagnosed with ovarian cancer are over 40, and the average age is 63. So it's very important that menopausal women, you have to know the signs. You have to know your risk factors. Endometriosis is a risk factor. Null parity basically means she's never been pregnant, or she's infertile. Use of ovulation stimulating drugs. And so menopausal women, they like to use hormone replacements, because when you become postmenopausal, you start to have issues because of the lack of estrogen. But estrogen is a driver. So personal history of breast, colon, or endometrial cancer, which are other hormone-dependent tumors, white race, and high-fat diet and obesity. So let's talk about prevention strategies. Again, we said there's no routine diagnostic screening for ovarian cancer at this time. So it's important that you talk to your doctor when you're having abnormal symptoms. And it's also important to talk to your doctor about risk factors. Should I get tested? Should I have genetic testing? It's okay to bring this stuff up, to speak with your doctor about this stuff, work with your doctor. And how can a woman herself reduce her risk? She can stay at a healthy weight. Being overweight is a risk factor. Being obese is a risk factor. And postmenopausal women, again, should not be taking hormone replacement therapy after menopause, because it is a risk factor. So if you already have a family history, and you're taking hormone replacement therapy, that's two risk factors, that's two things that can increase your risk. Birth control. So if a woman is on birth control for 5 or more years, she has a 50% lower risk of developing ovarian cancer compared to women who have never taken oral contraceptives. So birth control is very good for preventative measures for ovarian cancer. Tubal ligation or a hysterectomy. These are good ways to prevent ovarian cancer, but you need a valid reason to have the surgery. So let's say the woman has a family history, or she's had cancer previously and breast cancer previously. So she wants to do a prophylactic surgery. That might be a valid reason. So this is something else to discuss with your physician. It's very good to keep the lines of communication open with your doctor and talk to your doctor about these things, and so you guys can work together on a plan. If you have a family history of BRCA genetic counseling and testing, talk to your family. You find as physicians that people don't know their family history. Family history is important. Family history can help you with your own self and with your future kids. A bilateral salping oophorectomy, which is bilateral fallopian tubes and ovaries are removed, is the most prophylactic treatment for BRCA carriers. So in terms of case management and how they deal with managing ovarian cancer, and actually what public health initiatives are going on now or have been going on in the 2000s. So ovarian cancer is a rare disease. It's very lethal, but it's always, most times caught, not always, but most times it's always found in stage 3 and stage 4. The CDC has been rolling out campaigns since 2000, trying to research campaigns, trying to learn more about this disease, see if we can get better, more specific tests for ovarian cancer. And in 2008, the CDC launched a campaign called Inside Knowledge, Get the Facts About Gynecological Cancer. The campaign's mission was to raise awareness of 5 main types of gynecological cancer, which included ovarian cancer. So it encouraged women, pay attention to your bodies, understand what signs are reason to go see the doctor, talk to your doctor. In 2012, they went on a digital platform as well, and that digital platform reached over 2 million people. So they're trying to get the knowledge out there, and what's the best way to do it. 2015, new public service announcements, TV, print, and radio were put out. The CDC's goal was to expand public health knowledge through research and evaluation. At the end of the day, ovarian cancer is rare, but just because if it's a rare disease doesn't mean it's not a public health issue. This is killing many women, and it can be caught very early and treated very early if women understand their bodies, understand the signs, and know when to go speak with their physicians, specifically because there's no routine testing for it. Cervical cancer and other types of cancer, gynecological cancers that affect women like breast and cervix, there's tests for that. There's pre-screening for that. So it's very important that women know, specifically for ovarian cancer, they know their risk factors, they know their family history, and they know the research behind it, and they're educated on when to go see their doctor and what is a sign of this might be ovarian cancer, because it's not always caught because you can't feel it. So these are my references. Thank you.